Now we move to conditions that we typically identify when the baby is a few days old, but is still within the first couple of months of life. Vignette number 10. A very premature baby develops feeding intolerance, abdominal distension, and a rapidly dropping platelet count. The baby is 4 days old and was treated with indomethacin for a patent ductus arteriosus. Anytime you read an exam question, when a premature baby is first fed, that baby is in trouble. That is necrotizing enterocolitis. And that's what it is here. You need to stop all the feedings, use broad spectrum antibiotics, IV fluids, IV nutrition. Surgical intervention is resorted to if the baby develops abdominal wall erythema, air in the portal vein, or pneumoperitoneum, any one of which would indicate there is actually a dead piece of bowel. Now we move to vignette 11. A 3-day-old full-term baby is brought in because of feeding intolerance and bilious vomiting. X-ray shows multiple dilated loops of small bowel and a ground glass appearance in the lower abdomen. The mother has cystic fibrosis. This is meconium ileus. Let me give you the two ways you recognize the meconium ileus. One is if the radiologist says, we see the dilated loops of bowel, but we can also identify this ground glass appearance. It's characteristic. That's the inspissated meconium in the terminal ileum. But the second clue you have here is that the meconium ileus is not a disease in itself. It's a manifestation of another disease, which is cystic fibrosis. And the fact that the mother has cystic fibrosis leads you then to put 2 and 2 together and suspect the baby may also have cystic fibrosis. Now, the management of this baby has two components. We got to take care of the meconium ileus right now. Later, we will have to treat the baby for the cystic fibrosis. But as far as the meconium ileus is concerned, it's an interesting modality of management. There are two pediatric surgical conditions in which a diagnostic test also serves as therapy. And this is one of those two. What we do in this baby next is we do a gastrographing enema. You might remember gastrographing. We mentioned that when we were talking about patients that we suspected had an esophageal perforation. And we said we do a gastrographing swallow because we don't want barium to get out through that perforation and irritate the mediastinum. Gastrographing was safer. Well, gastrographing also happens to be a very hypertonic solution. When we do this gastrographing enema on the child, it will help make the diagnosis. We'll see the small microcolon of disuse. We'll see the pellets of meconium as the gastrographing refluxes into the small bowel. But it also, as it gets into the terminal ileum, that gastrographing, by virtue of its hypertonicity, draws fluid into the lumen and dissolves the meconium pellets, so that the actual obstructive phenomenon that is happening with the inspissated meconium is in fact ameliorated or treated by means of the gastrographing enema. I emphasize then the baby has to be treated for the cystic fibrosis because that's the main disease. Let's move to vignette number 12. A 3-week-old baby has had trouble feeding and is not quite growing well. He now has bilious vomiting and is brought in for evaluation. X-ray shows a classic double bubble along with normal looking gas pattern in the rest of the bowel. Does this vignette sound familiar to you? Yeah, we read this just a few minutes ago. This is in fact another child with malrotation. Now, we had already mentioned malrotation as one of those conditions we can recognize on the day of birth. But in malrotation, the bowel is hanging from the mesenteric vessels. It doesn't have a mesentery fixing it in place. And the duodenum doesn't have the normal C-loop arrangement. It's kind of a straight tube going down. And in that abnormally placed duodenum, there are bands of connective tissue that are called Ladd's bands, that as the bowel twists and turns in a direction or another, may cut off the second portion of the duodenum. So that's why we see double bubble in malrotation. But depending on how that bowel is rotating, it could be, like in this case, that for the first 2 weeks of life, the position of a bowel was such that the Ladd's bands were not obstructing the duodenum, the baby was not vomiting, and we didn't see any problem. And then the bowel has changed position, the Ladd's bands are now occluding the lumen of the duodenum, now the baby is vomiting, now we see the double bubble. And of course you already know what to do. Barium studies from above or barium enema to confirm the diagnosis, and then the surgical correction before this bowel twists anymore and dies. Vignette number 13. A 3-week-old, firstborn, full-term baby boy began to vomit 3 days ago. The vomiting is projectile, has no bile in it, and follows each feeding, and the baby is hungry and eager to eat again after he vomits. He looks somewhat dehydrated, has visible gastric peristaltic waves, and a palpable olive-sized mass in the right upper quadrant. This is hypertrophic pyloric stenosis. Let me read this vignette again with you, because this vignette gives you at least 2 good chances to recognize instantly the nature of the problem. We read on the first line that a 3-week-old baby has projectile vomiting. Let's talk about that for a second. If you or I have projectile vomiting, which means essentially vomiting with no effort, you sort of feel something coming, you open your mouth and the stuff hits a wall. That, in an adult, means intracranial hypertension. In fact, we would be very worried that we have a brain tumor. But when you see projectile vomiting 3 weeks old, you know right away that is hypertrophic pyloric stenosis. But if you miss that clue, there's another one. Because on the physical exam of a baby with hypertrophic pyloric stenosis, if we very carefully are able to palpate the upper abdomen, we can feel the pylorus. And as it happens, pediatric surgeons have a favorite term to describe that pylorus they can feel. They always call it an olive-sized mass. So you see this vignette gives you 2 chances to recognize right away this is hypertrophic pyloric stenosis. Now, resist the temptation to go for the answer that said, let's go to the operating room and fix it. Because these babies, by the time we see them, eventually are dehydrated. They've been vomiting now for several days, so they are dehydrated, and they often have the hypochloremic, hypokalemic metabolic alkalosis that goes with it. So those electrolyte and fluid problems have to be corrected first, and then we do the little operation that is called a pyloromyotomy. We're now going to read vignette number 14. An 8-week-old baby is brought in because of persistent, progressively increasing jaundice. The bilirubin is significantly elevated, and about 2/3 of it is conjugated direct bilirubin. Serology is negative for hepatitis, sweat test is normal. You are worried in this age that the baby may have biliary atresia. What we typically do, although this is a pretty elaborate workup, but the essence of the workup is we do an IDA scan after 1 week of phenobarbital therapy. The phenobarbital is a very powerful choleretic. It forces the liver to make a lot of bile and excrete a lot of bile. So we're stimulating the liver to put bile out. And then we do the IDA scan. If the IDA scan shows radioactivity in the liver, the biliary tract, and the duodenum, the baby doesn't have biliary atresia. But if the IDA scan, even with that stimulation, shows that all the radioactive material is in the liver and hasn't left the liver, we realize the biliary tract is missing. We then operate these children, and it's sort of a sad story, because only about a third of them can be properly connected surgically to where they remain in good health with a patent biliary tree. About a third of them, a repair is attempted, but it ends up not working and they need a liver transplant. And the other third, even at the first operation, there is no trace of a biliary tract that can even be attempted to be put together, and they need to go on to the waiting list for a liver transplant. So roughly 2 out of every 3 children born with this problem, actually I should not say born, they are not born with the problem. They are born with a biliary tree, and something, which we don't know what it is, destroys that biliary tree in the first few weeks of life. I should have said 2 out of 3 babies who develop this condition end up requiring a liver transplant. Let's move to vignette number 15 now. A 2-month-old baby boy is brought in because of chronic constipation. The kid has abdominal distension, and plain x-rays show gas in dilated loops of bowel throughout the abdomen. Rectal examination is followed by explosive expulsion of stool and flatus with remarkable improvement of the distension. When you read a question on the exam, chronic constipation, if the child was 4 years old, it might be a psychological problem. The child wants to make his parents angry and he holds on to his stool. But when you read that a baby at the age of 2 months is noted to have constipation, obviously this baby is not old enough to be playing games. Something is wrong with this baby, and you ought to be thinking of Hirschsprung's disease, aganglionic megacolon. I have to hasten to add, though, that not every patient with aganglionic megacolon presents like this one. Now, this one is a good example. This one, you can already suspect aganglionic megacolon, and you could do a baryomenema, and that would show distal normal-looking colon, which is the abnormal colon that has no ganglia, and big dilated colon above, which is the normal colon that is obstructed by the abnormal one, and then we would proceed with a surgical correction. But this disease could present almost at any stage in life, depending on the extent of the aganglionic segment. There are individuals who are born with just a very small area of aganglionic colon, that the colon that is above is able to push the stuff through. They may be constipated all their lives but not be diagnosed until they are adults. But on the other hand, if you have a baby with the entire colon aganglionic, they will present like the baby that has intestinal atresia. On the day of birth, they'll be distended, multiple fluid levels, nothing gets out. And then at the operation where we thought we were going to encounter atretic segments, we find out that the whole small bowel is there. And in that case, we then take the appendix, send it to the pathologist, and ask the pathologist to look for ganglia. If the pathologist reports there are no ganglia, you realize the whole colon is aganglionic. We do then a ileostomy, actually, and then at a later date do a reconstruction. In the previous presentation, the one that I read, once the X-ray gives you the suggestive picture, we make the diagnosis also looking by ganglia, but in that case, it would be a full thickness biopsy of the rectal mucosa. So let me repeat. Dealing with aganglionic megacolon, constipation is your clue. An X-ray might show you the abnormal bowel that looks normal on the X-ray, the dilated bowel, which is a normal bowel, and then the final diagnosis is full thickness biopsy, looking for the ganglia. Let's now review the ones we see a few days old, but still within the first 2 months of life. Here is a picture of meconium ileus. The radiologist has reported on the first of these two pictures that there is a ground glass appearance. Actually, there is also perforation, clearly seen on the second picture, where you see air, free air in the diaphragm, under the diaphragm above the liver. This is a midgut volvulus, which is one of the problems that can occur with malrotation. And here is the famous double bubble sign. You look at that baby on the picture and you see the large air fluid level to your right, the baby's left, which is the gas in the stomach, and next to it the smaller one, which is the first portion of the duodenum. Let's remind ourselves again that with this picture the baby might have duodenal atresia or annular pancreas or malrotation. Here's a picture of Hirschsprung's disease, the bariomenema. You see distal colon that is not dilated and then proximal colon that is dilated. And a very helpful yellow arrow from the radiologist marking the transition between the two. The diseased colon is the one that looks normal. That's the one that doesn't have ganglia. And the normal colon is the dilated one that has been obstructed by the segment that has no ganglia.